Good evening and welcome to the annual Wade Lecture. I would like to extend a really warm welcome to all our staff, students, alumni and supporters from around the world who've joined us for this evening's event. I am Professor Diana Eccles. I'm Dean of the Faculty of Medicine and Professor of Cancer Genetics. I've been incredibly proud over these past few years to be part of a faculty that has come together with colleagues from across the university and with our partners, the University Hospital Southampton, to be at the forefront of academic research and innovation leadership in health. This partnership was exemplified by our coronavirus response, which demonstrated what a wealth of talent we have here and how well we work in collaboration, not only with our colleagues in other disciplines and our university hospital colleagues, but also with the Southampton City, rising to this urgent challenge and translating our interdisciplinary research and enterprise activity to make a real global difference. This evening, I'm delighted to welcome Professor Sharon Peacock, who also contributed hugely to the coronavirus pandemic. She's an academic clinical microbiologist, award-winning clinical scientist, and an alumnus of the University of Southampton. As an executive director and chair of the COVID-19 Genomics Consortium, Sharon oversaw the development of a network that catapulted the UK to prominence as a leading authority on the generation and use of SARS-CoV-2 genomes as part of the pandemic response. Sharon is currently Professor of Public Health and Microbiology in the Department of Medicine at the University of Cambridge and a world authority in the use of pathogen genomics to provide actionable information to improve health. She's also a leading expert on antibiotic resistance and a range of infectious diseases. Her career has spanned nursing, medicine, and non-executive director role in a major NHS Foundation trust. So she has an eclectic combination of first-hand ward-to-board experience, and we're truly honoured for her to be with us this evening as our guest speaker for this year's annual Wade Lecture.
Well, thank you for coming to listen to my talk on the Great Escape, how viral variants emerged during the pandemic, a subject which many of us followed very closely over the last 2 or 3 years. I'd just like to start this lecture by thanking the University of Southampton a great deal for inviting me to give this Wade Lecture. Southampton is a place that's close to my heart, having done my undergraduate medical degree here, which I enjoyed greatly, and the university gave me a huge opportunity by offering me a place at university, so big thanks to Southampton. So on to my talk this evening, The Great Escape. Now, I consider that I can act as a narrator for thinking about how the virus mutated and evolved over time, because back in March 2020, I was asked by Sir Patrick Vallance, our Chief Science Advisor to the government, to develop a consortium that was able to sequence the SARS-CoV-2 virus, the cause of COVID-19, throughout the course of the pandemic. Now, just in summary, the UK was actually amongst the first to develop a capability to generate the viral genomes at scale and use this for public health impact. And we showed beyond any doubt that sequencing generated actionable information that supports an effective response. What do I mean by that? Well, certainly the very first genome that was generated by Chinese scientists allowed us to understand what this new pathogen was. It was a coronavirus. It also allowed us to rapidly develop the first vaccine against the virus, and over time it allowed us to understand how the human immune system and the virus were interacting and how the virus was evading our immune response. By looking at the sequence data, we could look at how variants were travelling around the globe and also how they were spreading within our local communities. I just want to go back to those very early months at the start of the pandemic, which many of us will remember for different reasons. But for me, the month of March 2020 was the month that I set up the COVID-19 Genomics UK Consortium, or COG UK. Now, this slide shows a timeline throughout March, and along the top of that timeline is red blocks for the number of people that tested positive for COVID-19, and underneath in green blocks are the number of genomes that we sequenced in that month. So the month started with a conversation with Sir Patrick Vallance and Sir Chris Whitty about the importance of developing genome sequencing capacity in the country to be able to track the virus over time. At that point, I wanted to converse with my colleagues, so I rang up 5 different academics who are expert in genome sequencing and said, did they believe that this was the right thing to do? And they agreed that it was. So a couple of days later, I circulated an email to a much larger group of people, around 20 people. And on the 11th, at the bottom of that image, you see there a cluster of us meeting for the first time at the Wellcome Trust building on Euston Road in London. Now, in that meeting, it was like a very unusual science meeting. We weren't talking about science. We were talking about where we would sequence, how we would do it, and who would do it, the how, where, and why of developing a sequencing capability for the entire country. That led us to develop a blueprint for sequencing, and we wrote that up over a couple of days over that weekend and submitted that to Sir Patrick Vallance, who then agreed to fund us to get this going. Now, we were waiting for the funds to come along, which was end of March, but we really got going much before that. So we put teams together to work at how to collect samples from people who were positive for COVID-19, how to do the sequencing methodology itself, how to link the genome data with the patient data. Who were they? Where did they live? What was the data of their samples? And then working out how to analyse that complex data and then feed that information back to public health agencies and the government. We wrote our first report to SAGE by the 23rd of March, and we also had a fully functional cloud bioinformatics structure to deposit our sequence data and do the analysis. So we got going by the end of March, when there were a very small number of known cases of COVID-19 in the country. Now, one of our strengths is that we worked together loosely as a meshwork or a network. We really played to our strengths. So there were 4 public health agencies of the United Kingdom, England, Wales, Scotland and Northern Ireland. We had 16 regional sites actually doing sequencing, and that was based in academic universities. We had project administration in Cambridge together with our central sequencing hub at the Wellcome Sanger Institute. So you can see this network, we worked together to take samples from patients in hospitals and people in the community who didn't require hospitalisation, and we wanted to sequence the virus to better understand it. Now, for patients who went into hospital, they had testing for COVID-19 in what's called Pillar 1. And on the left, you can see our sequencing capabilities across the country. And on the right, you can see all of the hospital diagnostic laboratories that fed in to individual sequencing hubs. So the colour codes are such that all of the purple dots, the testing labs, fed into a single sequencing hub. And so it really was a complex spider network of capabilities. Now, if you happen to get COVID-19 and you were tested in the community, your samples will have gone to the so-called lighthouse labs, which is called Pillar 2. And those specimens all went to the Sanger Institute in Cambridge for sequencing. Now, before I close this, introducing really the narrator of this story, I want to say a huge thank you to the consortium members. There were more than 500 people who gave up their time for free, most were volunteers, and who contributed to the pandemic response in this country by helping us to understand the virus as it evolved. So turning then to the virus, going back to December 2019, this SARS-CoV-2 virus emerged in China. And all humans, everybody was susceptible to infection because a new virus means that there's no immunity. And so if you're exposed to the virus, then you will become infected, whether or not you develop symptoms. And this really signalled the start of a major global pandemic. Now, I want to think about the virus and how fit it was on day one. It was a fit virus the moment that it emerged. Now, if we look at the figure on the left, the R0, or the basic reproductive number, what that means is that if I'm infected with this virus, how many people can I infect as a result of that? And the R0 for this virus when it first emerged was 2.8, so I would infect approximately 3 people. Now, if the R0 was 1 or less than 1, then you would find that the infection rates would actually slowly decline over time. But because the R0 was nearly 3, then the number of cases continued to expand over time. Not only that, the virus was a fit virus because actually viral shedding occurred before symptoms began in people who were infected. And so they could meet other people and infect them before they realised they were unwell themselves. And we found out after a period of time that a proportion of people who are infected with this virus have no symptoms at all. And so this ability to disseminate through the population was facilitated by these factors. Now we have things that we can respond to that. We wanted to protect ourselves through a combination of physical interventions, which includes distancing, fresh air, testing, tracing, isolating, and our lockdowns. We're all very familiar with that what happened to us, together with developing immunity. Now that comes through vaccine development and that rollout, which was highly successful, plus developing natural immunity. And so if I'm infected with this virus, I will develop immunity from it as a result. However, the virus and its ability to become fitter was not yet at an end because of viral mutations. Now, viral mutations are really just typos or mistakes in the genome of the virus that can potentially give it an advantage in its fitness and perhaps transmit to others more readily or evade our immune systems. And mutations in the genome are the basis of most evolution. Now, this virus is an RNA virus, and it already has a high mutation rate, up to 1 million times higher than in humans. And changes in the virus have the potential to adapt to their environment and continue to infect humans. Now, this is a slightly more technical slide, whereas on the top you have a schematic of the viral genome. This particular genome has around just under 30,000 points in it, each of which could become mutated. And in the pink bar, in just towards the end of that, is what's called the spike protein. Now, this spike protein is really important. It covers the virus, and the reason that the virus is called a coronavirus is that those spikes are inserted into the surface of the virus, and they coat it like a crown. Now, that spike is really important in the way that it interacts with us, because that's what homes in to the receptors on our human cells that allow the protein, the virus, to get into our cells in the first place, where they can then replicate. Now, mutations in this spike protein in particular are important because it can change the way our immune system sees the virus, and it can change the way that this virus interacts with our cellular mechanisms. But if we look at mutations, mutations really have three outcomes. If there's a typo in the genome, it can have no effect on the virus, and we don't really mind about that. Actually, a mutation can have a disadvantage to the virus, in which case we're unlikely to really observe that because the virus will become extinct very quickly. Although some viruses have mutations that have an advantage to that virus, which may result in what's called lineage expansion. And so that particular variant starts to expand in the population. Now, possible outcomes for genetic changes that we were really concerned about during the pandemic were the following. First is that a mutation could lead to increased transmissibility between people, and we certainly saw that happening. The second is that we could have altered disease severity. Now, that could go up, so people could become more sick from COVID-19, or down, in that they could develop very mild disease, for example, like a common cold. We're also concerned about immune evasion, and so when a virus infects us, our immune system is immediately alerted to that and will try and fight off the virus. But the virus can find ways to avoid that immunity, and that's what's referred to as immune evasion. And finally, some mutations lead to changes in the readout from some of the diagnostic tests that we were using. Now, if we look at the WHO definition for what's called variants of concern, which again is something we heard a lot about over the pandemic, variants of concern are those that have mutations which lead to either increased in transmissibility or a detrimental change in epidemiology, i.e. the spread of the virus, increased in virulence or change in clinical disease pattern, or decreasing the effectiveness of our measures that we use to try to control the virus. So the ABC of variant assessment, as we were going into the pandemic, is a particular variant of SARS-CoV-2 more transmissible? Does it exhibit immune escape? Does it cause more severe disease or even less severe disease? The difficulty is spotting those important variants, particularly as there were thousands and thousands of variants emerging over time through this process of mutation. So a system was put in place where we could escalate the classification of variants. So in the first instance, we were looking at all the possible variants that were emerging, many of which were not particularly relevant to our concerns, but we were horizon scanning to see which ones had mutations which we would predict could lead to, for example, more transmissibility. If something came up on our radar, then they would move into a variant of interest and they would be monitored over time to look to see whether these particular variants were spreading more rapidly or causing more severe disease. Now, if indeed that was demonstrated to be the case, then they would move up to variant of concern, and we've heard about the variants of concern. I'll talk about it a little more shortly. What we didn't ever see, fortunately to date, was a variant of high consequence, where a variant would emerge which would have a fundamental challenge to our ability to actually control it, that would cause very severe disease, etc. So I'm glad that we haven't seen that variant of high consequence. Now I'd like to come back to this idea of trying to find the needle in a haystack and finding a variant that actually we think is going to become important in the future. So if we look at this graph, this is normalized to 100%, so on any given day the proportion of variants up to 100% are coloured in. Each colour is a particular variant, i.e. a particular genetic pattern of the SARS-CoV-2 virus. So at the very beginning of the pandemic in wave 1, you'll see at the start of that graph, March 2020, there were a very large number of variants circulating in the country. And in February and March 2020, from genetics, we can actually work out that there were thousands of different variants introduced into the country, probably around the half-term period in February 2020. So in wave 1, there was no one particular virus that was adept at more transmission or immune evasion. As we went into wave 2, there was a particular lineage called B1177, which appeared to start expanding. So that's the red blob in wave 2. Now that started to appear and actually took up around 50% of all infections that we sequenced for a period of time. But when we studied that in detail, we had to conclude that this was a summer holiday variant. That's what we nicknamed it, because actually it was introduced into our country and expanded rapidly, but it was originated from Europe. It had no particular characteristic that would lead to more transmission. It simply was introduced into our country many times after people travelled on their holiday. But if you actually start to look at November and December, at the halfway through of wave 2, you'll see a lime green variant, which actually, if you look further on in the graph, is called alpha. Now in the early weeks it was just a few percent, but it actually very rapidly completely replaced all of the other variants, and it's a very striking graph that it just basically swept the other variants out of the way, and the reason was it was more transmissible. So it outran all of the other variants around and it completely replaced it. And then you also see on that graph Delta, which then appeared in April 2021 and did exactly the same to Alpha, because that was again more transmissible than Alpha. And of course we now have a variant called Omicron circulating. Now I want to come to the Alpha variant for just a moment, because this is how we think about variants as they emerge. Now this was our first variant of concern. It has in the past been called the Kent variant. It was detected in the south of England quite early on, 20th of September 2020, but didn't really get going until December and January. The surprising thing about this variant is it had acquired 17 of these typos or mutations in its genome, and that was really not expected because it had changed much more rapidly than scientists were expecting. More worrying, when we looked at the mutations, they were very much focused in this spike protein, which I've already mentioned is the part that's stuck on the outside of the virus and interacts with our cells to gain entry into our cells. And so that was very mutated. We found that it was about 50% more transmissible than other circulating variants. It had no significant impact on vaccine efficacy. There was an increased risk of hospitalization if you were infected, but no increase in death once you were admitted. Now this has been nicknamed the Grinch variant for various reasons. Certainly it spoiled people's Christmas period because they could no longer get together. to have their Christmas celebrations. And certainly we asked our consortium to go back to work as they were deciding to down tools for a week or so to have a break, because we really needed to track this virus over time. And so I think the Grinch variant is an appropriate title. So really, when we look at these variants, this process of replacement of one variant by another has continued since the graph that I showed you a moment ago, which ended in Delta. So we now have waves of Omicron coming through, which dominate what is infecting us at the moment. Now, this is perhaps the most complicated graph I'll show this evening. And what it looks at is relative fitness of SARS-CoV-2 variants one against another. Now, on the y-axis, what that shows is the fold increase in relative fitness over the original Wuhan lineage. So Wuhan lineage has a number of 1, and if you're 1.5 times fitter than that, then you go up to 1.5 on the graph, or 2, 2.5 and so on. And then on the x-axis, you have the date of lineage emergence. And the circle is the proportional to the cumulative case count, how many people were diagnosed with this particular variant. And what you'll see is an ever upward trend. So the big circle in the middle called B117, that's alpha, and then you'll see going up the curve to BA1, which is Omicron. So over time, these variants are becoming fitter, largely through their ability to transmit from one person to another. So it's a constant battle between these variants. The act of mutation is completely random, but they're selected out for their ability to spread between us. And if they're spreading more effectively, then they will replace the previous variant. Now, this really sits right back to the work of Charles Darwin, who is who had a lifelong study of the natural world, including his survey voyage on HMS Beagle. And I've put there some details around his joint publication with Alfred Wallace about the theory of natural selection, where something will become fitter than previous variants or forms of that particular species, and actually replace what was going before. And of course, he published on the origin of species in 1859. Now, one of the things he described was what's called the Darwin's finches. So in the Galapagos Islands, he was looking at finches and at the beaks to see how beaks varied in finches to allow them to adapt to particular niches in their environment, for example, seed size. And his natural selection indicated that individual organisms of a given species, they do show a wide range of variation for a characteristic such as beak size. But these characteristics are suited to an environment, and they're most likely to survive and breed successfully if that characteristic allows them to do well in that environment, for example, the seed size. So these characteristics then allow them to be perpetuated and survive in the next generation. And I believe that what I've shown you here is that this is exactly the case with the SARS-CoV-2 genome, where you have a particular virus which, through a random process of mutations, develops an ability to have a characteristic such as increased transmissibility. And then that will survive and is passed on to the next generation and the next generation, whilst other variants are kind of defeated, if you like. So what drives the selection of variants of concern over the pandemic? Well, the first is uncontrolled high rates of viral transmission and infection. The more a virus infects ourselves, the more chance it will have of having a mutation, which then, by random chance, goes into a part of the genome that provides it with a selection. These are the latest figures, or some of the latest figures from the WHO. It shows you the number of confirmed cases globally and the number of deaths. That's a very large number, and this gives the virus an advantage in terms of allowing mutations to arise. The second selection is really if the virus is transmitting in a population where some people are immune and others are not immune. And so this provides a pressure for the virus to change so that it can actually escape the effects of our immune response. Now, if we go back to beginning of January 2022, and we see the share of people vaccinated against COVID-19 at that time. This is a graph of a selected number of countries, from the UAE at the top down to Nigeria at the bottom. And you'll see that there was a large variation in the number of people who are vaccinated against COVID-19. but many countries were actually relatively unvaccinated against COVID-19, for reasons of which we can discuss later perhaps. But that allows variants of concern to emerge. And the worrying thing in particular is that COVID-19 vaccine doses administered per 100 people, this graph shows that actually it's the low-income countries that have the lowest vaccine doses administered per 100 people, whereas in the high income and upper middle income, the numbers are much higher. So you'd expect variants of concern to be particularly focused in areas where people are unvaccinated and have a very high level of infection. The last two drivers of infection, of emergence of variants, I'm not going to discuss in detail, but the first is prolonged infection in immunocompromised people. Their immune systems are down because they have disease or, say, cancer chemotherapy, and they can't clear the virus properly. So that perpetuation of virus, it's like a training ground for the virus. The virus can actually develop mutations, and some of those mutations can give them an advantage in the person, and then they can persist. And if that particular variant is passed on to others, then this is probably how alpha emerged with so many mutations. It had like a training ground in an immunocompromised person. It developed a lot of mutations. It was a fit virus, and it then transmitted out to the rest of the population. The other thing that we worried about a lot during the pandemic was human to animal passage, where the virus can change considerably between human to animal passage and then back from animal to human passage. So finally, what's the future scenarios for the SARS-CoV-2 virus? Well, there are possibilities including extinction. It's unlikely that this virus is going to be extinct anytime soon. It's a very fit virus, and the latest Omicron variant suggests that it's getting fitter in terms of transmissibility over time, although fortunately its severity is going down, so Omicron tends to lead to much less severe symptoms in most people. Global eradication has become something that largely the world has actually discounted as a possibility. There were some countries that considered global eradication as well as elimination through a zero COVID policy, but the countries that actually implemented that are now backing away from that, having vaccinated their populations. So what we're really left with is something called endemicity. We're going to be living with this virus for the next 100,000, 10,000 years. So this isn't going anywhere fast. What comes after Omicron, which is what is circulating across the world at the moment? It's a key thing to think, are there other variants around the corner? I would say expect the unexpected. When Alpha emerged, that was something of a surprise scientifically that it had so many mutations, and you have to be prepared to say that that something else might emerge. So you need to be prepared to detect what is coming next. My own feeling is that Omicron is very fit in terms of transmission. It generally doesn't cause severe disease, and I think that for something else to emerge, there would need to even be more transmissible or better at escaping immunity, or both. But the virus doesn't have an advantage from causing more severe disease. It has an advantage from being more transmissible. Future severity is unknown, and it's hard to predict it, but I think that even though it could go up, down, or stay the same, I believe that over time the severity of infection is likely to go down. Now, certainly vaccines prevent severe disease, but will still allow infections. And so what comes after Omicron? Well, I hope a vaccine that can prevent reinfection altogether or infection altogether. But what I would say is that we are witnesses to our own history as it emerges. And actually, much of the wisdom that we've accrued, that I've accrued, have come from actually living through this period of history and looking back over it to make some sense of it. Well, I'd like to thank you for listening, and I very much look forward to answering your questions about the Great Escape, how variants of concern emerged over the pandemic. Thank you.
Well, thank you, Sharon, for a truly interesting talk. And now we're going to move on to the questions that have come from the people listening to you today. So, is the molecular mechanism underlying the high mutation rate of RNA viruses known? And the follow-up question is, how does the mutation rate of SARS-CoV-2 compare with other RNA viruses?
Yes, okay. Well, thank you for everybody dialing in, first of all, to listen to my lecture. I'm really grateful to you all, and I'm really looking forward to your questions, so please do keep them coming in. The mechanisms of the mistakes, the typos that are made, is well understood, and basically the virus lacks a sort of proofreading capability, which means that the fidelity of the genetic code being transferred over really accurately isn't as good as it should be. If we look at the rate of mutation of SARS-CoV-2, it's actually lower than HIV and influenza, for example. These are viruses that we're very familiar with. So it's around sort of a half to a quarter of the rate of, for example, influenza and HIV respectively. But there is quite a big but there. If you look at the natural course of the SARS-CoV-2 virus, you would expect around 1 or 2 mutations a month to appear if the virus is constantly circulating through the population. The but comes because when you have millions and billions of infections, the number of mutations that arise in the virus is actually potentially very high. And so the number of cases kind of, I suppose, is probably one of the most important things in the virus being able to have a large number of mutations, some of which will have an advantage. But
it's unprecedented, really.
Absolutely, yes, certainly in our living memory and our history.
Yeah. Thank you. So our next question from Professor Holgate. Molnupiravir mutagenesis is now being seen in global sequencing databases, in some cases with onwards transmission. Should we be concerned?
Yeah. Well, I think the key thing is that for all types of treatment that we give patients who are severely unwell, they are important, and resistance to those drugs were seen relatively early on, and they are important. However, for me, the key is, of course, vaccination and preventing people going into hospital in the first place. And so a vaccination was really key. However, with the emergence of resistance, there are several things that we need to do to these drugs that are used in hospital. The first is to continue to sequence the virus, and so we sequence the virus, we track these mutations that encode resistance to monoclonal antibodies and to antiviral drugs. And if it gets to the stage where the resistance does emerge, then in the same way that you would treat any virus, such as the HIV virus, you're going to have to move on to alternative treatments, actually. So at the moment, I wouldn't be overly concerned, because the virus appears to be, the way it's evolving is around transmissibility. And so unless that kind of genetic change that makes it resistant to a specific drug, that virus then really starts to spread and it has a transmissibility advantage as well, then I wouldn't be so worried. And if you look at the step from the Wuhan, the original Wuhan variant, to step up to Alpha was 50% more transmissible, and then Alpha to Delta, that was 50% more transmissible. And if you see these increments, it's much of it is about transmission. So in answer to this really important question, I would only be concerned if there appeared to be a particular transmissibility advantage in the healthy population, which after all is where the virus is doing most of its transmission and spreading.
Yeah, thank you. Some have opined that fitter variants become less severe in their clinical effect. So very linked. I have read, let me just understand what the question is. I have read to this, it misunderstands viral evolution. Is that correct?
Yes. There's been a lot of speculation and discussion and scientific kind of analysis around the link between pathogen evolution and fitness. But from my perspective, a pathogen evolution, to start with, is purely a random effect. I mean, mutations occur randomly, and then they are selected for based on their characteristic. Transmissibility is the thing that's really been selected for. And if you think about it, if a virus becomes more lethal, i.e. it actually ends up with people in hospital and actually unfortunately dying, there's very little advantage to that virus because it's unlikely to spread. Whereas if the virus was actually less severe, for example, we had a very mild cold that didn't stop us going to work or didn't stop us going to meet our friends, that's much more likely to be transmissible. So I think that the link between a pathogen evolving into a more severe a severe form, I think that link is not something we have seen. We've seen the virus going in the opposite direction, which means that actually there's less severe disease, and it's going more towards the kind of the common cold end at the moment. So it has debated a huge amount of debate actually, but often there is very little biological advantage to an organism becoming a sort of a major killer rather than becoming a cause of the common cold actually. But a great question, and you could talk about that all night.
Yeah. So what are the chances of a new variant emerging at this stage in the pandemic, and how would it differ from what is currently circulating?
Yeah. Well, new variants are going to emerge the whole time. So the virus, through natural selection, will be if there's something that's particularly more transmissible, will be emerging, and that's what we're seeing with Omicron and its sort of sub-variants. And it depends what we really mean by variant. But Omicron at the moment seems to have backed itself into a corner. It's very successful. It doesn't cause as severe disease as previous variants. And what's happening now is variants of Omicron are kind of spilling off. So before, Alpha and Delta, they were really quite different lineages. So if you think about a family tree, they were kind of very different branches of the family tree. At the moment, the whole world is infected with Omicron, which is a single branch of the family tree. And then those sub-branches, all of those kind of progeny, are coming off. Now, those are what's beginning to circulate at the moment. We're seeing new variants emerging, which are actually more transmissible. So the thing that we're likely to see new variants emerge. The question is, what does that mean? Yes. I think they're likely to be more transmissible. So at the moment, for example, in the UK, we have something called BQ1 circulating, which is a sublineage of Omicron. And others are beginning to emerge that can transmit faster than that. So they're beginning to take over. I think the one thing I would think we have to look out for is, do any of these cause more severe disease? And a kind of a lineage of Omicron or sublineage, I think it would be quite surprising if it took that turn. But there's something on the block which is being called Kraken. It's XXB, and what's happened is that two different viruses have recombined to make a new virus. It's in the Omicron lineage, and I think what we have to do is look out for the behaviour of those what we call recombinants, which is a bit of a virus, the same virus attached to another bit of a virus, which can bring mutations together to make sure that that isn't associated with more severe disease. More severe disease or complete resistance to vaccination would be the two things I would be particularly concerned about. Right now, there is nothing that looks like that. So, I think overall the chances of kind of a true Kraken monster emerging, I think is quite unlikely. And if it does emerge, the biggest characteristic will be transmissibility, based on really observing and learning from the last 3 years of watching the virus.
Yeah, fantastic, thank you. So the question here, comparing SARS-CoV-2 with measles, is its mutation rate higher or lower? And it says here with high live vaccine coverage, you might expect some differences.
Yeah. Well, that's a good question. And the thing about measles is it's actually highly transmissible. Yes. And so that's the key thing around measles. But measles can be, the variation in measles is less, so a vaccination can actually be highly successful, a single vaccination. So if you look at the vaccination for SARS-CoV-2, we're having to think about whether we need to reinvent it. And there have been trials of vaccines, and in fact the vaccines we're getting at the moment are to particular variants, sort of two variants together. with measles, there is a single vaccine, which has been a very stable vaccine over time. And so I think the difference with that is it's a highly transmissible virus, but we're not seeing this incredible turnover of evolution that we do. So that with COVID-19, we're constantly following the tail of evolution, whereas with measles, as I say, the vaccine that we have is actually effective. It's an interesting comparison, actually.
Yeah. What do we know about long COVID in relation to the different variants?
What a good question. I do wish I knew the answer to that.
Yeah.
And one of the things about the pandemic is it's told me to be humble about what we do and don't know, because you learn and you have to accept what you don't know. And I just don't think that we know enough about the basis of long COVID.
Yeah.
If I was to speculate, I would say that it's unlikely to be mainly driven by variants rather than the host. So if we look at long COVID, it emerged from the start of the pandemic and during a period when we were unvaccinated and people were having quite severe disease. But actually long COVID has continued to occur despite all of the variants. Intertwined with that, of course, is our increasing immunity and vaccination, so we're actually more protected. We don't get such severe disease generally. But my sense is that that the host factors, what's in your own DNA, your genetic message and your genetic code, and how your immune response responds to infection is going to be much more important in defining the basis of long COVID. So I think the key thing from my perspective is really understanding the human genotype versus long COVID, and those studies are being done. I mean, there's been a lot of human genome sequencing done actually over the pandemic, in particular looking for potential new treatments. But that, I believe, is going to hold the clue rather than the variant. Perhaps variants would have a small part to play, but I think that the biggest part to play is going to be, what genes that you carry in your body, the variants that you carry in your body.
Yeah. And of course, our more recent variants we won't know about yet anyway.
Yeah.
So as one of our alumni, there are questions here about your career. Who would you say has inspired you throughout your career?
Actually, somebody who has inspired me hugely. Well, there's lots of answers to that. I think the first person that inspired me because he changed my life was Professor David Wilton, who is now a retired professor of biochemistry. So I struggled to get into university and I failed two times. I was a mature student, failed 2 times, and I kind of rang up Southampton and said, can you just see me? I was sort of a bit cheeky. And David Wilton, who was the admissions tutor at the time, said, okay, come in. And he asked me to write an essay on why I thought I should be accepted. I wish I'd saved that now because I don't know what it would say. And he interviewed me and he asked me why I wanted to be to train in medicine. And it was wonderful because I convinced him somehow, and within a month I was a medical student. So he inspired me because what he did was take a risk. And so the kind of heroes of the science world that we sometimes think of course, I do have absolute role models and people that I admire very much throughout history. But the people that I really admire are those people that are going to stick their neck out for you and actually make a change. Because if you make a change like that, it changes your life completely, and it therefore changes the life of everybody around you. So my first hero would really be David Wilton for giving me that break and allowing me to come to Southampton. And of course, the institution itself had the rules that allowed him to be able to do that. And so I think Southampton is a fantastic place for that reason, because it actually opens the doors to people with different backgrounds. So that might not be the answer that the person watching was expecting, but certainly my kind of, the people that I admire most are the people that are willing to be brave in the decisions that they make to help others.
Yeah, what a fantastic inspirational story. Do you think we need to move into combination treatment therapies to have greater effectiveness, as we do with some other viruses?
Yeah, that may be important if resistance emerges. So we go to combination therapy often to try and prevent resistance emerging. So TB, HIV, they're very classic examples of where you give two drugs together to reduce the risk of resistance emerging, or to have effective treatment right up front when you don't know what the resistance is. I don't think that we are in the situation yet where we're having to use combination therapy. However, when you think about it, the direction of travel is that we are not ramping up treatment for a very large proportion of the population. And for me, the key is to prevent infection in people who are likely to get the most severe symptoms from their infection. So actually most people now who have COVID, they have a rough time of it, they feel like they flu-like, but they recover. The people who are not going to recover are the people we've heard about all along, and those are the people who are vulnerable because they've got predisposing conditions to get severe disease. So the question is whether you would move into dual therapy. But if I had a focus of action, it would be to try and prevent infection. From my perspective, I don't think that we're at a stage where we need to roll out dual therapy. But sequencing, will be key to that, because we won't know if things are resistant to viral drugs until we do the sequencing. Because if somebody doesn't recover and they're given an antiviral, that's probably because they have an underlying immune deficit. And if they don't recover, is it because of drug failure or because of their underlying condition? So for me, often as a scientist, you're asked to predict the future.
Yes.
And as I say, coming back to this humility thing, I would say, let's watch and wait. And I think better than predicting, being willing to change your mind and actually follow the evidence. I guess people might think that's a bit of a kind of a cop-out, but I do think that if I've learned anything, is not to be too dogmatic about the way I think.
You need the information before
you do.
You, yeah.
Absolutely. Yeah.
So slightly linked to that, this question: when can someone who's immunocompromised feel safe?
Such an important question. And it depends what feeling safe actually means. I think that it's difficult to predict the future. I would say that with the new subvariants of Omicron coming along, particularly something called CH1.1 and potentially the Kraken variant, which I think they may replace what we have at the moment, we may have a new surge of cases because they're more transmissible than what's circulating. So when is it safe? I think that's a nuanced decision by individuals based on the level of their immunocompromise, the life that they lead, the life that they want to lead, and the protection that they can take to actually protect themselves in their day-to-day, mask wearing and so on, and being in a ventilated space and not being in a crowded room. I wish there was a kind of a point in time, but I think we're still riding the crest of the wave in terms of all the variants coming out. And as I say, I think that it'll wax and wane. One ray of hope, I think, is really the spring and summer. So when the spring and summer comes and people can go outside more, they can open their windows more and so on, and there's less gathering of people in a closed space, then that will make it easier for people, I think, who are immunocompromised. But actually, as I say, it's a very personal decision about the risk an individual will take versus the lifestyle that they want to lead. So unfortunately, there isn't a single easy answer to that.
Yeah. Speaking of opening windows, did you see an impact of the social restrictions and behavioural shifts, for example, lockdown, on the genome of the virus? And did fewer new variants arise during those times?
That's also a good question. What we saw during lockdown was that basically the level of infection just went down, and that, I think, going back to Alpha, for example, with the lockdowns, the level of infection went down because you didn't have mixing. There was no change in that variant; it didn't shift. And we haven't seen it. What we've seen is these waves of Alpha, then Delta, and then Omicron, and that wasn't dictated by lockdown. Lockdown and getting away from the virus was a response to what was coming. It was a response to something that's more transmissible. So it was like the horse before the cart. The transmissibility came first, and then we went into lockdown. And going into lockdown, didn't influence the variants that were coming along.
Okay.
But there was a second part to that question which
It's disappeared.
Okay, I'm sorry. I'm sorry to the listener, but I'm just trying to think what it was. But certainly the variants are actually on their own mutational drumbeat and their own kind of natural selection, and we are responding to that rather than the other way around.
Yeah.
What I would also, I remember now. So what I would also say is that with lockdown, whilst we're locking down in our country, other countries are not in step lock, if you like, with that. So if we're locking down, but actually a variant is not being locked down in another country, then that could be surging. And you know, if we're looking at trying to prevent new variants emerging, it does come down to trying to reduce the number of infections that we have, which is my point on my slide, where you know, in low-income countries where there was low level of vaccination, huge amount of infection, and part of trying to drive down the risk of emergence of variants actually is to reduce the number of infections that occur. So it's difficult to try and quantify whether that actually has reduced the emergence of variants, but because so many countries had really very high levels of infection going on, I think a lockdown in one country wouldn't have influenced the overall emergence, because this is so much bigger than one place or one country.
How will sequencing be used during the next pandemic? And any differences to its use during this pandemic?
Well, there's going to be similarities and differences. The similarity is that the sooner we can sequence an emerging pathogen, the sooner we know what it is. So, as I say, the Chinese sequenced the SARS-CoV-2 very early on in January and released that genome data. And so we knew that it was a coronavirus, and we knew it had a spike protein, and that became the target for vaccine development, because that's the bit that our body sees and our immune system is focused on. So in the next pandemic, we'll be using sequencing as rapidly as possible. So we will need sequencing. I think that will we use it in different ways? I would like to think that the experience we've had around providing a network of sequencing capabilities, applying that as soon as possible to understand whether variants are emerging that are of significance for our control, and learning from this pandemic, which means we've got to very rapidly develop methods for sequencing, we've got to develop analysis tools, but most importantly, if there was there's a couple of things I would change. One is data connectivity, getting data from one place to another, really important. And the second is getting data to policymakers and decision makers. So the next time round, it will be less about the technology. I think it will be more about the connectivity of data and connectivity of information, which leads to decisions that impact all of us, actually.
Yeah, very important. So if you could give your younger self any advice, what would it be?
I guess that I'd say it's not over till it's over, because I thought as a 16-year-old, I left school at 16 and I worked in a shop, and actually I never thought that I would be doing what I do today. And what I've done is, as I've grown one step at a time. So to my younger self, I'd just say, you know, kind of be quite brave and think you can do anything you want to, and keep pushing on doors. I mean, I actually trained as a nurse before I trained as a doctor, and I didn't dare tell anyone I wanted to train as a doctor because I thought people might actually laugh at me. But I think the advice to myself is be brave and take it one step at a time, and see what happens, and enjoy the journey, actually.
Yeah. Okay. Do you think there's going to be another pandemic in the future?
Yes.
And can you speculate?
That's an easy one. What do I need to speculate on?
The timing, I think it's.
The timing, okay. Yes, there will be another pandemic. It's a question of timing. If you look at pandemics and epidemics around the world, I mean, certainly the epidemics that have occurred, we've had SARS, MERS, Ebola, Zika, SARS-CoV-2. The drumbeat of what's emerging is coming along quicker than if you look at the previous 100 years. And the reason for that, I don't know the timing, But the reason it's getting faster is because we are encroaching on the natural habitat of wild animals. And we also, the wild animal markets, what happens is that people, under any circumstances that become very close, living very closely with wild animals, that increases the risk, because wild animals carry viruses. Actually, many, like bats, they carry them naturally because their immune system's adapted to have viruses in them. But they could be harmful to humans, and often they'll jump into an intermediate host, another animal, before they then pass on to humans. So the timing is unpredictable, but the solution, I believe, is for us to treat the planet and the creatures on it in a way that respects what they need for their habitat, but for us to have less encroachment on and this kind of abutting with wild animals. And then, of course, the global spread of people is like kind of cranking the engine, really. So yes, timing uncertain is the very short answer to that.
But a good message in there. I think we've come to the end of our time
really quickly,
already.
didn't it? That went so fast.
And it's a shame because we've got a lot of questions for you. So thank you. And thank you very much for your fascinating talk and for being our annual Wade lecturer today. It's been really great hearing from you. And thank you to Professor Diana Eccles for her warm welcome. In a moment, you will see a short poll on your screen, which we would kindly ask you to complete. And for any of you that want to watch the lecture again, we will be sharing the footage over the coming days, so keep an eye on your inbox for details on how to access this. So thank you once again, Sharon.
Thank you so much.
Thank you again for joining us, everybody, and good evening.
Bye.